Welcome to Metabolic Matters Podcast, where we embark on conversations with thought leaders, disruptors, change agents, and passionate souls. Together, we'll delve into what truly matters to them. And you'll learn how to metabolize this newfound wisdom so you can transform your own metabolic health. Now let's meet today's guest. With cancer expected to affect half of us in our lifetime, and now the leading cause of morbidity and mortality worldwide, I am constantly on a mission to seek a glimmer of hope on how best to prevent and manage this pervasive disease. Over the last decade or so, revolutionary tools in the realms of diagnosis, treatment, monitoring, and prevention have emerged. These non-invasive solutions offer a paradigm shift, circumventing the traditional invasiveness associated with cancer care, and thereby promising less discomfort, reduced risk, and improved patient outcomes. Advancements in medical technology and research have given rise to a diverse array of non-invasive techniques that contribute to various facets of the cancer continuum, from early detection through sophisticated imaging modalities to personalized treatment regimens that spare patients from burdens of invasive procedures. The landscape of non-invasive cancer solutions is expanding rapidly. Furthermore, these innovations extend beyond the treatment phase, offering non-invasive methods for continuous monitoring of cancer progression and the development of preventive strategies based on individual risk profiles. Today's discussion delves into the multifaceted utility of non-invasive cancer solutions, exploring their role in revolutionary cancer care. We'll dissect a few of the technological breakthroughs, clinical implications, and ethical considerations around these approaches. It is my honor to introduce to all of you a man with a distinguished career and profound commitment to advancing the field. Dr. Datta is the chief scientist at Datta Cancer Genetics and has become synonymous with the pioneering efforts in liquid biopsy applications. As we delve into the discussion on liquid biopsy in the cancer space, Dr. Vineet Datta's insights promise to unravel the nuances of this transformative technology. His research, publications, and contributions to the field position him as a thought leader, providing a bridge between cutting-edge scientific discoveries and their real-world implications for patients grappling with cancer. Join us. I know you'll be inspired and impressed with what's on the horizon in cancer care. Welcome, everybody. I am incredibly honored to introduce you to someone I've had the privilege to meet on a few Zoom occasions that has really inspired me in what the future of oncology holds. And I want to start by introducing him just by something I read on his LinkedIn. Actually, I think encompasses so much of why he's here today with all of us. So I want to highlight Dr. Vineet Datta's amazing sort of tagline on his introduction on LinkedIn, which beyond being a medical doctor and beyond being a health tech enthusiast, he literally states that he is unapologetically driving the science of hope. That just absolutely gives me chills to even say that. It gave me chills the first time I read it, and it gives me chills again to repeat it. But I want you to tell us exactly how you're doing just that. Thank you and welcome.
Thank you, Nasha. It's great to be here. So, as you mentioned, I'm a physician by training. I'm not a naturally trained genomic expert. I have done that on the go. I'm clearly a genomic enthusiast, and my interests reside in the two extremes of the cancer ecosystem. Clearly, one is looking at earlier detection, which can hopefully lead to superior, better outcomes. And the other is the stage of the mid-late stage cancer, especially dealing with refractory, relapsing, difficult cancers. And that currently is clearly a challenge for majority of the patient community. And how can we use smart genomics to tackle that not just using genomics, but I think smartly integrating a plethora of various different scientific subsets that are now coming to the forefront, and how do we use that working in close association with experts like yourselves, the clinical community, patients and caregivers, with the end outcome clearly to look at better outcomes.
So how did you come? Because you were, I mean, you've got a really impressive resume, which will have been introduced before our conversation started today. But you really moved from a very kind of clinical environment into sort of a consultant environment. How did you become the genomics enthusiast that you are today?
I think a lot of that was brought about by the ecosystem. I've largely been trained in the UK, but a lot of my roots are based in Southeast Asia, especially in India. And we've clearly seen in various parts of the world how late diagnosis leads to a serious challenge with regards to adverse outcomes, not just from the standpoint of adverse outcomes for the patient, the family, the caregivers, but also from a financial impact that has. So a lot of my interest largely evolved in terms of seeing how best we could think out of the box, create an ecosystem that could help us explore from a research, academia, and a clinical forefront what options, opportunities could be used in a safe, credible, and ethical manner to provide patients with options beyond what's currently available today. And I think having been with the group now for the last 8 years, I've found this to be a perfect ecosystem which allows us to do exactly that, which is to think out of the box and explore options for patients across various different subsets of cancers. Again, the ecosystem is huge. I'm clearly not going to say we are looking at tackling most, but we have clearly identified hotspots and areas of concern. And clearly looking at this late stage cancer space is clearly one of them. And over the last few years, we've done a lot of work, which is all largely focused on original research work that is now translated into offering clinical solutions that can help clinicians explore various therapeutic options for patients who are today struggling with treatment.
My gosh, I love that you've repeated this word several times throughout these last few minutes, which is the concept of ecosystem. This really lands very true in our community. We're very much terrain centric. We want to understand just as much as why and how the cancer expresses versus just the what is the cancer itself. And one of the things that you and I are going to unpack a little bit today, and hopefully in more detail over the coming year, is just tackling the complex ecosystem of cancer. And one thing I'd like to just sort of set us up in the discussion is that increasingly, I personally am finding as a clinician that we seem to continue to be asking the wrong questions in the oncology space. And that we've sort of spent the last, since 1914, really classifying cancer as just simply a genetic disease with a single target and a single treatment approach. And not to say that genetics don't have a major role here, but I'm not certain if they're the whole enchilada or if we're approaching them in the way we should be. And so, for instance, for me, when I look at the hallmarks of cancer, a lot of our listeners know about this. What is always striking to me and what I'm curious about, and will then allow you to dive in and tell us your interpretation or thoughts about the complexity of cancer, is, well, what makes those hallmarks express to begin with? That's where I feel like I spend my time and my curiosity and my energy in studying. And so with that, I would love to hear from you sort of what you think the origins of cancer are from your opinion, your experience, what contributes to the expression or suppression of some of these genetics and epigenetics and ecosystem factors that are giving rise to the cancer space.
Yeah, so the reason why I mentioned that as an ecosystem, and the reason why we will discuss during our discussions how we want to target the ecosystem using an encyclopedic approach rather than a very myopic unilateral approach, and why that makes sense for us is purely because the disease is quintessentially an extremely complex one. And over the last few years, we've seen major technological advances. And I think we're in a position today, the reason why we are discussing these complexities and how those different hallmarks have an adverse and potentially a beneficial impact for the patient is because we are now able to identify these different layers of biological elements that contribute to the cancer development. And I think it's in that space we are now starting to very actively talk about a concept that we started talking a few years pre-COVID, in fact, which is looking at an integrative multiomics approach and how can you use that smartly to gain insight into the cancer, not just as a biological phenomena, but also in terms of how can you define a precision-based approach. No two cancers are going to be the same, so there's no ways in which we would want to look at bucketing them in a similar format and a system in that space. So when we are talking about the abnormal proliferation of these cells, cells which are ignoring the body's signal to stop, when they're multiplying significantly within the system, they're crowding out and then they're being shed into the bloodstream to look at a spread within the system. We know that in a healthy body, these cells that are dividing and growing are doing so in a relatively orderly fashion. And we know there is an intrinsically protective mechanism within the body that will look at eventually causing death of these cells by design. And we know that design is apoptosis. But we then also understand that some of these processes, which are naturally protective mechanistics, will go awry. They will go bad. And that's really where the acquisition of those hallmarks, as you discussed, really impacts our transition from a normal cell into a cancer cell. And these hallmarks typically are extremely complex. And they are complex from various different mechanistics. This is not just about, as you mentioned, a target, a drug. These are complex phenotypic changes. These are molecular changes that are being largely propelled into the space of uncontrolled growth of cancer cells. They are trying to evade the normal growth suppressor mechanistics which the body's throwing into the system. They're resisting a cell death. They're trying to replicate immortality, new vessel generation, something that we call angiogenesis, which is going to be a precursor for spread, and then eventually looking at metastasis. So typically the problem that we face is that these cancers, largely these solid tumors, will release intact malignant tumor cells into the blood circulation. These are what we call as circulating tumor cells, and they will be responsible for the spread of the cancer. And as these cells originate from the cancer, we do now have not just innovative, but largely various different technologies that will determine and detect various different fragments of these cancers, whether they're tumor cells or whether they're nuclear fragments. And a large number of very, very intelligent groups are evaluating them from various different perspectives of clinical utility. I think what's important is also to understand, because the biology is complex, if you are able to determine mechanistics that help view the complex biology, not just from a single window, but from multiple windows. So things that we discuss, for example, expression profiles of markers, then they help us to look at determining much, much more information. Now, all of that information may not be useful from a theranostic standpoint, but there clearly could be information that we will identify. And we also need to be extremely mindful that the current techniques that we are using, when we use a very esoteric approach, it does not benefit majority of cancer patients. And that's very important to understand. So while we may feel that we are practicing a precision-based oncology approach, the end outcome that we are looking at is to determine, one, biomarkers that could help define a therapy. But then subsequently, the phase 2 of that discussion has to be, we've identified the targets, but are they now actually working for the patient or not? Because if we're not able to achieve the end outcome, then it really then ends up, unfortunately, being an academic exercise. And the aim is to see how can we look at benefiting both overall survival, progression-free survival, improving lifetime for an individual patient, but ensuring majority of that is not spent in the hospital firefighting side effects of the treatment that he or she has been provided.
Wow, you first of all, so many juicy nuggets. And again, this is my world. I think I've been studying this for a long time and through this. So a lot of people, this might be new concepts. So I want to give a little like chronology to this. It was not that long ago when I was in, private practice, probably 2008, 2009, when I started running across, maybe even before then, maybe 2005, when I started running across the potential for testing tumors and blood types that were becoming more available to our patient, not just in research environments. In the beginning, they were very much poo-pooed, even disregarded. I mean, I remember all the way up till 2013 that clinicians and researchers were saying that there were no such things as cancer stem cells or circulating tumor cells. Do you remember that? That was a decade ago, right? And so that was this place where I would come out talking about how we could be testing for these things. And yet people are like, well, how can you test for something that doesn't exist? It is now a decade later. Fast forward, almost every major academic institution runs some form of this evaluation. We'll talk about that here in a moment. But what I'm also seeing are two things. One of them, I really appreciated that you brought up the concept that sometimes this just becomes an academic exercise, that there's a lot of information, but it's not actionable. So it might be interesting, but it's not actually changing outcomes. So that's one piece of this. The other piece is that we actually do have some very validated, actionable information, and yet we're not doing anything with it in those big academic institutions. So I will see patients who come and get this beautiful report of tissue assays, and it's like somebody looks at it and goes, yep, that's interesting. Let's go over here and still do standard of line care, first, second, third, fourth, whatever, until the failure. And then they look at incorporating the knowledge gleaned from these actionable data. So I would love, wherever you feel like touching on those 3 points of just sort of the history that not too long ago, we didn't even think this existed, right? Didn't believe in it, that there's a lot of just sort of intellectualizing of this. And then there's a lot of there's good actionable data, but we're not doing anything with it. Can you speak to those points?
I pretty much reside in your boat when, 2016, 17, we were talking about the concept of multiomics and looking beyond the DNA in terms of an element of sequencing a cancer. Majority of clinicians who I spoke to did come back and say, not in my lifetime. And just look at where we are 10 years down the road. And I think what's happened in the ecosystem is that I think some of the initial successes of what's been achieved by using genomics is clearly propelling this into the next phase of the fact there's an acknowledgement now that maybe we don't know enough. And just the fact that we've practiced cancer in a particular way, there clearly have to be other elements of ways to tackle various different elements of the cancer biology until we are better equipped in terms of understanding what those challenges are, which we will clearly discuss today, is also to try and evaluate how can we try and overcome some of them. So I've been poo-pooed as well. That's fine. It's in a space where I'm relatively thick-skinned. And when you're on a mission which is upstream, I think it's on an ecosystem where you're dealing with a domain which is clearly imperfect, and the aim is to try and make that imperfect ecosystem less imperfect. And that, in my view, is a positive progression in that process. So when we talk about things like, for example, as you mentioned, sequencing, again, sequencing today has become a standard of care for majority of cancers, especially for inherited genomes. So, for example, looking at germline, there's clearly very, very good data which looks at various hereditary cancers. So the hereditary breast ovarian cancer syndromes and other elements. And clearly there are now various different offerings available at various institutes that provide us information And that information can be used in a variety of ways. It can be used for diagnostics, it can be used for prognosis, we can use that for treatment selection using various different biomarkers. We're now doing exciting things like looking at tumor mutation burden, we're looking at instabilities of the cancer, we're looking at actionable alterations which can help us define things like immunotherapy-based elements. I think the challenge has been that the two most commonly utilized purposes of using that sequencing have been either to determine on-labeled use of approved therapies,
Correct.
okay, or they've been largely to determine clinical trial eligibility.
Yes,
And I think what we've done is we've worked ourselves into two extremes within the system. And I think the challenge has been for us now, how do we find a middle pathway that helps us define various different elements from my perspective personally as a clinician, and I speak as an individual. If I had a choice of using smart genomics to tailor make a therapy for an individual using certain FDA labeled drugs, where both the safety profiles are well established, but we do know that there's an ability to work beyond a certain organ system or the organ agnostic space that we've been discussing now over the last few years. I would clearly explore that for my patient over a clinical trial where only the safety profile has been established, the efficacy hasn't, because that's the endeavor of the clinical trial. And I think to the point that you made, I think majority of the barriers that exist today in terms of very efficiently implementing them have to be basketed, in my view, in two or three different areas. One is obviously clinician knowledge, but the challenge is not just the knowledge. The challenge is in our training. When I trained as a clinician within that space, I remember beyond one chapter of genetics, we read nothing else. And that's how we've been brought up. The fact that I continue to read every day, every week, every month, every year, is because of my interest. And it's part by default because this is what I do. It's also out of my interest. So I think as you look at building in training mechanistics, you build greater confidence in terms of utility of those different tests. I think the other element of that is also how do you smartly interface genomics into the clinical workflow? How do you build it into the clinical pathway? How do you build it into your EHR system? How do you look at utilizing them into a format that can then be used from a clinician standpoint? The fact that we've got limited clinician time, it also warrants us to use smartly molecular science with experts like, for example, counselors. Those who have much more information, have time to speak to an individual about not just potential benefits of a genetic test, but also what can be the limitations of that test. So you provide a credible and a balanced opinion to an individual patient before he or she decides to go ahead and do that test. So I think there are those different elements that come into play as part of that ecosystem. And I'm sure as we discuss really why some of these cancers are difficult to treat, we'll understand more and more as to why you can't bucket them into just one box.
Thank you. And I think before we dive into that I just want to reiterate a point that you brought up about that really there are sort of like two main pathways. You follow this algorithmic NCCN in the US guideline standard of care that you don't move to the next tier until quote unquote, the language that's specifically used in this arena is when the patient fails the treatment. However, I very much want to flip that to when the treatment fails the patient, because that is actually the reality. And so what I feel that this type of testing offers is is a higher probability of success for the patient responding to a given therapy. So that's one point. The other point is you talked about clinical trials. And most of these testing has been designed to help find what clinical trials will the patient fit into based on that data. And I really love that you brought up this point, because I'm going to be very generalistic, but I want the lay person to understand what clinical trials mean. And it's not across the board 100%, but it's a pretty good generalization that a phase 1 clinical trial is simply a safety profile. It's just to make sure that this drug will not kill you outright. I mean, I'm being very blunt, but that's the reality. A phase 2 is when we move into what is the maximum tolerated dose to get a clinical response. Like where can we do? Where's that edge of too much, not enough, and is it actually starting to make a little wave into response in that patient? Phase 3 is when we actually are looking for progression-free survival, overall survival, an actual response to the therapy. That's well before it enters into, hey, now it's available to you as a consumer outside of a clinical research model that has a lot of tight parameters around it and is not very accessible by most. So I want to point that out, because the average time it takes to go from that phase 1, and even prior to, by the time the IRB is accepted and everything goes through, to the time it lands in our ability to use this as a clinician with our patients, is what they call the 17-year gap. It's a real thing. It takes an enormous amount of time and money to get that out there. And at the end of the day, I can't recall off the top of my head, you might know, how many drugs actually don't even make it to a phase 2, a phase 3, or into the mainstream. So a lot of patients might land in trials that never even see the light of day, and may not even themselves see the light of day after a short period of time. And so I feel like what this space in the last decade is starting to offer is, as you put it, a science of hope. We are starting to look at things in a different way. And so that segues nicely into the number of patients that come to myself or my colleagues and to your colleagues who have stopped responding to those first algorithmic treatments, are now progressing wildly. And now we're what they literally call in standard of care, throwing them on palliative therapy alone with no expectation of cure. So I would really like to understand what does make a difficult cancer? Like, where does the utility of this type of testing come to play with those late stage non-responsive refractory cancer types? Take us on that journey.
Okay, so clearly there are benefits of how you create a guidance system, because you need to create a system so that when you've got majority of cross-border clinical practice, you need to define certain governance metrics, and I get that. I think what's important for us to understand is that when we're dealing with the complexity of what we're talking about, the greater we understand about some of these cohorts, and largely I'm focusing on this mid to late stage space where we've got these refractory, relapsing, certain cancers that will do far worse, that will be much more difficult to treat. Typically, we know outcomes for brain tumors, for glioblastomas, for pancreas, for triple negative breasts. We know where the challenges reside, sarcomas, some of the hematobiliary cancers. So from that perspective, it's almost looking at an ecosystem where to tailor make a precision-based therapy, every patient is a clinical trial.
Wow, beautiful.
And that's the analogy I work with within the ecosystem. And then it's a very science-focused, yet a pragmatic approach of trying to identify targets, trying to overcome why some of those therapies are not working, and also balancing the fact that you do need to provide to patients where the immune system has been decimated by progressive use of therapies that have not worked. How do you then bring about an incremental benefit for those individuals, and trying to balance that off with a relative preservation of quality of life? And that's an extremely tight rope to work in. And we know from increasing data that's coming through as to why targeting cancer stem cells, as you mentioned, are difficult. We also understand in much more clarity now, thanks to genomics, why those drug resistance properties of those cells make them immune to subsequent therapies. We also understand that only a handful of mutations will be identified in patients, and within that ecosystem, our knowledge is limited to now, or not having explored various epigenetic mechanistics that are in play within the ecosystem, and how can we use some of them which are both initiating and propagating tumorigenesis. So that brings into the complexity of the fact that different cancers will behave differently. What we haven't touched about, very, very important, heterogeneity.
I was so waiting for you. Yes, thank you.
And the element of the fact that within the ecosystem, why is it that the same treatment doesn't have the same effect across a cancer ecosystem space, even if the organ systems are similar? And when within that, the mutations of each cell are completely different to another, they impact the vulnerability of those cells. And therefore, the heterogeneity that we see across the different ecosystems align that they will not all respond to the same treatment, even if they are boxed in a certain subset. And that makes then cancer cure a difficult stage to work in. I think the other element is the challenge is late detection. It's varied across different geographies. Again, a large amount has to do with effective screening strategies. We know they're limited to certain organ systems, but we know for a fact that cancer detection later stage, clearly an association with reduction of survival. We know that across various different organ systems. We also understand that there are various hypothetical models that clearly look at the fact that if you can downstage from a stage 4 diagnosis to a stage 3 diagnosis, then clearly there is a modeling that suggests there will be fewer cancer-related deaths within an ecosystem that you study over 4 or 5 years. Again, these are mathematical, they are retrospective analytical models that have been developed, but clearly they are suggesting that the earlier you start treating, the better chance you've got. The other element which is important for us to understand for clinicians or for patients who are struggling with these relapsing cancers is there's also increasing data to suggest that when you initiate a therapy that doesn't work, it just doesn't work for that cycle. It also impacts successive cycles and limits and reduces the probability of success for some of those cancers and for some of those cycles. So the important thing for us to really understand in terms of a critical question is how does a cancer cell survive? How does it have the ability to grow into a distant environment? And clearly successfully founding a colony for metastasis is the detrimental impact in that process. And within that, the reason why some of these cancers are coming back, whether it's after initial treatment or whether it's after surgery, is either because the initial treatment did not get rid of all the cancer that was there within the system. Some of those cells have survived and have spread and have started to grow in different elements of that space. Or if a surgery did take place, some of those cells have been left behind. And we have what we're dealing with is a micrometastasis, and those cells are evolving. And we touched upon the point of heterogeneity. And the complexity there is the fact that if you've got within a tumor different elements of cancer that's growing and dividing, and they've got different pathways, or there are not within the same organ but different organ systems, it is possible that you may treat one part of the cancer using a driver mutation and a drug that is extremely successful, but that mutation may not be the driver in a subsequent area. And that's the reason why that cancer gets left behind. And then it becomes almost near impossible to track all these multiple complexities, because when you look at a follow-up through, for example, a liquid biopsy, where we're using a blood sample and looking at identifying these smart DNA and RNA and cell-based activities, we'll see that those changes have taken place. Some of them have been brought about by the treatments we've induced, and others have been brought about naturally by the cancer or the interface between the cancer and the immune system. So the bottom line is, whichever nugget that you pick up, there's an enormous amount of complexity in that structure, and we've got to acknowledge that we don't know everything in that space. So the more we look at driving those data points to those clinicians to go back and say, well, look, there's much more out there, and it's beyond even just looking at the approach of therapy and treatment. What we haven't discussed at all, which we certainly will before we sign off, is how do you build in preventive healthcare measures into that space? Because they are impacting not just screening but treatment. So what are we eating? How are we exercising? What are the toxins from the environment? What are our lifestyle toxins that we're imbibing into the system? They all have an impact in terms of not just how do we prevent, but how do we also modulate the cancer for those patients who are struggling with those treatment options?
Whew. It's like drop the mic there, because you covered so many topics, and this is precisely what it is that we look at in the Metabolic Training Institute of Health, what our clinicians in our network, Metabolic Approach to Cancer Network, are trained in evaluating for, to all the things you just spoke to. I want to highlight a few pieces for folks who this might be new ideas for, in that the way we've typically treated cancer for the past 100 years is through this maximum tolerated dose approach. Our research models are based on this, and our application of it clinically is based on this. And yet we're getting emerging evidence to what Dr. Datta just spoke to, which is that speaking to that heterogeneity, meaning there's a lot of different things happening in that same tumor, that same, cell even. I mean, there's just a lot going on, that it's not homogenous, that you just give one treatment and it should take care of everything. In fact, it leads to, more often than not, this sort of whack-a-mole game, I think, is an analogy I've been able to share with my colleagues and my patients, to say, okay, great, we knocked out this one line or this one personality of the cancer, but we actually invoked another. So one of the examples in the ovarian cancer space is that surgery can be one of the most powerful therapies for this. And it also triggers, the surgery itself triggers TGF beta, transforming growth factor beta, which is one of the key drivers of ovarian cancer. So it's this catch-22. And what I feel is coming from the work that you do and so many others like you in this field is that it's giving us an opportunity up front to see a few targets simultaneously in parallel, to gently nudge at and kind of give a guardrail to how those cells could respond to whatever treatment you're giving it, to make them more responsive to whatever treatment is ideally chosen, but to also anticipate some of the secondary implications of those treatments. To me, this is an incredibly exciting time of research and expansion on what we're just, like you said, just like I don't even think we're scratching the tip of the iceberg. I think it's so much, but it gives me hope on what we can be doing differently and doing better. And so, because the other piece I want to make sure before we tie this up a little bit in a moment, a lot of people may not even know what we're talking about when we talk about testing. So I know people know that they usually go in for surgery, get a biopsy, and then that goes to pathology for them to say, oh, this is a adenosarcoma, or what cell type, what embryologic or what cell type is this? That's how we've also classified our treatment approaches most often. Well, what we're talking about here today is a little more sophisticated than that. We can actually look at the personalities behind that pathology and start to understand even more actionable targets that we can sometimes hit with a single drug to multiple targets versus a single drug to a single target, or multiple dietary, lifestyle, off-label drug, nutraceutical, herbal, intratumoral, surgical, metronomic chemo, fractionated radiation. I mean, a multitude of therapies that can actually have more of a shotgun effect and hitting a lot of that ecosystem that we're talking about here. And so could you just briefly speak to what we mean when we're talking about this more targeted precision testing, both from the maybe tissue assay beyond pathology and the liquid blood biopsy space, in case someone's really new to this discussion?
Okay. I think we've clearly seen over the last decade the potential benefit of molecular science and how that has the ability to transform various strategies, not just to diagnose, to stratify, to monitor, but also to treat cancer. And within that space, a lot of very, very good genetic research over the last few years by various groups across the world has clearly looked at driving a lot of these solutions into clinical practice. And I'm absolutely confident that as these benefits of these solutions get increasingly established, you will see this having a far greater adoption. And then will come the challenge of how do we make sure this is accessible to the patient cohorts, and at what price, and the value we perceive as part of that outcome. So when we talk about sequencing, when we talk about genetic sequencing, largely what we've done so far is either focus on a certain specified group of genes, which are parts of the coding part of the system, or they are part of the what we call as the exome, or they're looking at sequencing the entire genome. Now, the choice of how we decide what approach we want to take is clearly dependent on a number of different things. So what is the end application of what we want to achieve? Is this purely a research activity? And we want to learn more, and as we get more data in the coming years, we'll be able to go back to that data because we've done a wider sequencing? Or are we clearly saying we want to look at a very narrow targeted approach to identify various different biomarkers that may have an impact in terms of looking at various drugs, as an example? Clearly, the targeted panels are what are being increasingly used today. They are being used because they help us provide, one, a greater depth. They also help us provide actionable data that we can use, genetic mutations and fusions. They help us with providing us relevant data in a much quicker turnaround and at an acceptable cost. We also need to understand that cost is also coming down as we establish greater utility tools within the ecosystem. The challenge for us has really been that while we've looked at various data sets that look at matching the genome subtyping across the driver mutations, unfortunately, we only are able to capture data for up to about 4 out of 10 patients in that ecosystem. But the number of patients that subsequently end up being treated with a specific genotype matched drug is only about 1 to 2 out of 10. So for all the hurrah of using the garb of precision medicine, if we go by a very narrow myopic approach of just looking at the exome structure, then majority of the patients today do not benefit from that approach. And that clearly is today a challenge for us within the system. So this is largely also being defined by how we're devising various strategies for patients, looking at the different subset of mutations, rare or otherwise, and how we providing our trial discussion and our enrollment process into the ecosystem. The fact that we've got both intra and intertumoral heterogeneity further adds to the complexity, because then we're really trying to identify which is really the true mutation which is driving that process. And I think that is really where the challenge comes into the equation. I think very, very early, about 7-8 years ago, one of the things that we understood from our approach was clearly going to be the fact that there are a myriad of different mechanisms. There are various different interactomes that are in play. These are from coding to transcription to regulation to protein synthesis. Majority of that is used today in clinical practice when we look at DNA and IHC and other elements. But the fact is that there are clearly interplay of various different pathways. We also understand that there are various post-translational modifications that take place when we're looking at these approaches. Clearly, there are elements of clonal evolution of some of the resistant pathways that are ongoing. And as you look at those pathways, each of them then progressively contributes and progresses towards sustaining survival and proliferation of those cells. And with that complexity that's brought into the equation, to oversimplify this to say, oh, a single layer approach is going to work for the patient, then from my perspective doesn't work. And that's really how we conceptualized what I call as the ETA, which is the encyclopedic tumor approach. So you're trying to capture and conceptualize data from multi-layered tumor interactomes. So this includes your DNA, your RNA, your pharmacogenetics. How are you trying to combine a drug with high efficacy and tolerable side effects, and also trying to look at the in vitro response of viable cells, either in blood or in live tissue. So that then brings into equation this multi-omic approach, and using that as a strategy to achieve a tandem blockade across multiple signaling pathways, in my view, is a viable strategy to use. And that's a strategy that we've used very, very effectively over the last 7-8 years. And I will certainly share with you some really exciting data that we presented at ESMO a few weeks back in Madrid, where we've now got real life experience of how we have benefited patients both from a progression-free survival as well as ensuring stability of disease in extremely heavily pretreated patients. And I think they are the most complex to deal with.
Agreed. You know, you just, again, you're speaking to these pieces that you're talking about. Historically, we could only look just into the tumor and recognizing that wasn't enough information. You guys are taking it beyond that, as well into what's in circulation, which can often have a very different personality. I see this happen all the time, where a patient will change over time. And that's very, very common. It's way more common than we give it credit for. And then in my world, we look a little bit deeper at the actual microenvironment of which the tumor took root, or those cells in circulation might create a new colony elsewhere. So we as integrated providers look at that part to be as inhospitable to new colonization as possible. And so when we bring the best of what standard of care, like amazing research in the field and what you're doing with what we're doing in the integrative alternative, I hate that word alternative, but complementary integrative space, we have even more potential to make a difference for our patients' overall survival rate, progression-free survival, and for sure their quality of life. And so when I know we are going down a lot of rabbit holes here and a lot of people's heads are probably spinning, one of the things I want the listeners to know is that Dr. Vineet and his team are partnering with MTIH to help make this complex discussion very applicable to the clinical environment. And so we're looking at creating a 6-part training series for clinicians, doing a much deeper dive in what we're very much skimming over the surface of today. So we're kind of planting the seed that will be launching by the first quarter, middle to the end of first quarter of 2024. So we are hoping that this not only becomes an incredible tool and resource for our clinicians in our network, but beyond, because there are so many clinicians who are overwhelmed by this information, don't feel that it's clinically applicable, and need the tools and the resources and just the awareness that these tools exist. And to what Dr. Vineet was saying, they're not perfect, but they are a heck of a lot better than having nothing at all. And so they're constantly evolving. And I know that Dr. Vineet and his team at Datta are very committed to improving upon these offerings in their world, as well as so many other tissue and blood biopsy companies around the world. And so with that being said, what are you most excited about in the future of this field? I mean, you've kind of alluded to some of it. You've talked about the science of hope here. What do you see happening with this brilliant information that is moving from the bench to the bedside in supporting our patients?
Well, I'm truly excited by what 2024 is bringing, which is, I think, our collaboration of building together. I think the foundation is going to be education. and at various elements. And I'm delighted that we will bring in real experts who know their stuff from a science standpoint, from the molecular side to the clinicians. And my role is largely to link all the exciting things that are happening at the lab and looking at that data and how can we make that useful for the clinician and the patient. You brought about a very important point. So the acquisition of those hallmarks that we discussed and which we will talk about in 2024, they are happening at multiple levels. And you're absolutely right. We are looking at the genome and the epigenome in that space, part of the transcriptome. But clearly, there's much more out there. There's the proteome, there's the metabolome, and all these different omics that are coming in. They vary in their complexity. And it's important to understand when we're dealing with approaches and strategies which look at these relapsing refractory cancers. What we are doing at our level is to identify a multi-analyte molecular analytical platform that will look at synchronicity between the DNA, the RNA, the in vitro chemosensitivity, looking at an label agnostic mannerism of driving a multi-layered treatment approach. But clearly there has to be much more beyond that. And I think this is really where various experts come in from those different elements. So I think from my perspective, clearly there are two elements to this. One is clearly early diagnosis, no doubt. And this is something that's going to be very, very important for us to look at. But I think the trends are really now looking at these advancements in biomedicine, where the shift from the one-size-fits-all approach to a truly tailored approach, I think is really the way to go within the ecosystem. Clearly, our data has shown that when you look at exploring those difficult and relapsing cancers, and you start looking at those unexplored vulnerabilities of the cancer, it is possible to obtain a durable objective response. It is possible to look at a disease control. It is possible to look at in a certain subset population how you define treatment benefits within that space. You're right, the system isn't perfect. There's clearly room for improvement within the ecosystem, but I think it's also for us to now understand how can we use the latest scientific advances, genomics and beyond, and how can we improve access, and how can we start having more training, less unsupervised genetic tests available within the system, which are not understood clearly that well. But the important thing is really for us to understand that there are multiple factors in play at the cancer level. And they will have an impact not just on our strategies for screening, but also on our strategies for treatment. And as we discuss this, what we've seen in some of the recent data that we presented at ESMO, it is possible to look at using some of these smart strategies that help us look at defining a personalized approach that looks at a multi-analyte approach for solid organ cancers. And it is possible to obtain stable disease, improvement in progression-free survival, providing they're smartly utilized within certain subgroups. And to the point that I made earlier, where I'm buoyant by this integrative approach, because it is just not about screening. It's about our healthy eating. It's about regular vaccination. It's about avoiding some of the toxins like tobacco and alcohol. And what else are there in terms of the interface of the environment with our genome? And they are critical strategies, not just in cancer prevention, but we also need to understand they have hugely detrimental effects on cancer itself. So while you're being treated, you also need to look at what are you eating? How are you living your lifestyle? What are clearly impediments within the ecosystem that will adversely impact your outcome? And we clearly know there is now pockets of really exciting data that's coming through, which is starting to evaluate what else can you do beyond just the modern medicine, the surgery and the radiation that you can bring about to have a sustained outcome improvement within the system. And that, I think, is clearly what excites me. So the fact that there's an unknown out there is something which is very exciting for us. And clearly that propels us to do much, much more in terms of our journey. So Nasha, your and my work has just begun.
I agree. I feel like we are just getting warmed up. And so just for the listeners to know, I've had the distinct privilege of seeing some of the data that Dr. Vineet's team at Datta have put out there on patients that are patients who, as he described, these very difficult to treat patients who've had multiple experiences with therapies that just were not effective for them, or things just are not quite as robust as we'd hope to be from standard of care alone in the lines of therapy. I've gotten to witness firsthand, and patients have gotten to experience firsthand, how much this can change progression-free survival, overall survival, and quality of life. And when we bring both those worlds together, as Dr. Vineet just mentioned, of weaving in what I do well, which is the terrain support, and my colleagues do well, we have something really quite spectacular. And so for me, the future looks like every single patient, that someday I would really like for everybody to have the ability to screen for early diagnostics early on, because that ultimately, prevention is truly the only cure for cancer. So to be in that space, as he mentioned at the beginning, focusing there and helping people understand what it takes to stay healthy, to become healthy and stay healthy. That's one area that we're also very committed to focusing on at MTIH. And then the other side is when sort of, frankly, all hell breaks loose and nothing else is responding, we need to be a lot more assertive and much more precise and personalized in that approach, which is where, if we could have every single patient take pause from whatever standard of care is no longer serving them, take a little break, get a new updated test information from a company like Datta, where you then can look at the sort of evolving or emerging personality of that cancer, looking at the other metrics that we gather from other meaningful data. For instance, C-reactive protein is just a good example I like to use here, that standard of care therapies will fall short if a patient already has that level of inflammation arising, because that leads to more multiple drug resistance and more side effects of the treatment and poorer prognosis. So somebody with my training knows how to directly address that inflammatory process and support the patient so they can have better response to whatever therapies seem to be matching them in their needs at that time. So I just look at a time and a place where we will have a very distinct roadmap for every single patient, every single time, whether it's in a preventative state, a direct in-process treatment state, or a maintenance of a remittive state or manageable state. This is the future of oncology care as we know it. And so I don't know about the rest of you, but personally, I'm left with a profound sense of optimism for the future of oncology care. And through having lived through a journey of cancer myself and recognizing that it's filled with lots of road bumps and challenges along the way, it is great honor with luminaries like yourself, Vineet, that are leading the way. And so thank you for sharing of your insight, your expertise, your vision, and to our collective future precise health, where we are converging all of the best of these both worlds and redefining the landscape of cancer care for, frankly, generations to come. And so I can't wait to see what we're going to be putting out there together to start helping other clinicians have access to and become educated, empowered to utilize this approach in a very meaningful way that will absolutely make a difference in their patients' lives. So thank you so much for your precious, gracious time, and we continue.
Absolute pleasure. Thank you for having me. And I look forward to doing a deeper dive into our sessions early next year. So we keep at it. Education is the key for all stakeholders, including ourselves.
Agreed. Thank you, Doc.
Thank you very much.
Are you a healthcare practitioner feeling increasingly alienated in a system that seems to have lost touch with its heart? Do you find yourself yearning to reconnect with the essence of why you entered this field to begin with, to truly help people? If so, I invite you to consider a path that will rekindle your passion for medicine. Our Metabolic Approach to Cancer Master Course, starting February 7th, offers not just an education, but a heartwarming journey back to the roots of why you chose this profession. Born from my own journey as a teenager grappling with a cancer diagnosis, and navigating a failing medical system. It is a testament to the power of transformation and the human spirit. We will dive deep into a patient-first methodology, blending standard of care with naturopathic and complementary therapies, all while focusing on true healing and prevention. Explore our Terrain 10 concept, a compassionate approach to understanding the multifaceted nature of cancer, as well as other metabolic diseases. It's about giving you the tools to not just treat, but truly connect with your patients on a deeper level, addressing their unique health needs. By joining this course, you won't just gain knowledge, you'll reclaim the joy and fulfillment of being a practitioner. You'll be part of a community that values patient-centric care, underpinned by the latest research and ethical practices. In this era of healthcare, where so many feel frustrated and unable to provide the care they deeply desire, ask yourself, is it time to reignite my passion for medicine, to be part of a movement that restores the soul of healthcare and places the well-being of my patients at its very heart and soul? If these questions touch a chord with you, please join us. Enroll today at matc.terrain.network. That's M as in Mary, atc.terrain, TERRAIN.network, NETWORK. And use the code podcast20 to get 20% off your course fee. Together, let's bring warmth, empathy, and genuine healing back into the heart of healthcare.
Thank you for joining us for this episode of Metabolic Matters. We hope you found today's conversation insightful and empowering. As we wrap up today's episode, we want to take a moment to acknowledge the incredible team and supporters who make this podcast possible. First, we'd like to thank our production team, Alex Sanchez, Cindy Kennedy, Jessica Gilman, and Lynn Hughes, for their hard work behind the scenes. Our theme song was written by Julie Newmark and performed by Whiskey Flower. And finally, we want to thank you, our listeners, for tuning in and being a part of the Metabolic Matters community. Do you want to learn more? Please visit our website, metabolicmatters.org, and you can follow us on Instagram. If you liked this episode, please leave us a review and share it with your friends and family. And if you want to help support our mission, spreading awareness and knowledge about metabolic health, reach out. We'd love you to join with us. Also, don't forget to subscribe to our channel and hit the notification bell to stay updated on upcoming episodes. We have so much exciting content coming your way. Until next time, stay curious, stay empowered, and remember, your metabolic health matters.